Hello, I'm Dr. Raouf Amin. I'm the director of the Division of Pulmonary Medicine at Cincinnati Children. I have a special interest in the management of children with chronic lung disease, but more importantly, I have also an interest in the management of children with sleep disorders, specifically children with sleep apnea. Sleep medicine is a clinical interest of mine as well as a research interest of mine, and I have been practicing sleep medicine for the last 25 years. Dr. Stacy Ishman, she joins me in this discussion this evening. She is a co-director of an upper airway center. It's a multidisciplinary program that we developed 4 years ago, and she will introduce herself.
Thank you. My name is Stacy Ishman. I'm a member of both the Pulmonary Division as a sleep medicine physician, and I'm an otolaryngologist or ear, nose, and throat surgeon. I also have a special interest in sleep apnea, and I've been doing research and taking care of children with sleep apnea for about 10 years now. I joined Cincinnati Children a couple of years ago because I was very excited about the prospect of the Upper Airway Center, which Dr. Amin and some of my colleagues started a few years ago. Our goal is to give multidisciplinary care to kids who have sleep apnea after their tonsils and adenoids come out, or for infants who have craniofacial issues or small jaws and don't yet have big adenoids and tonsils. We have a number of different providers from a number of specialties, including ENT, plastic surgery, genetics, pulmonary medicine, sleep medicine, radiology, and the list goes on. But we are able to give a comprehensive evaluation for kids in a combined clinic and really try and figure out the most appropriate way to take care of these kids as we move forward. I think the first question today is, what is sleep apnea? Sleep apnea is really pauses in breathing. We look at sleep apnea as both obstructive and as central. So there are some people where the signal from your brain doesn't tell you to take a breath. That's central sleep apnea. Our clinic tends to focus more on obstructive sleep apnea in the upper airway center. And that's when they try and take a breath, but the full breath doesn't come in and out, and it might be a partial or a complete blockage in breathing. It's not normal to have more than one pause an hour that's obstructive in children. And so that's the point at which we really start looking at what kind of alternatives or what kind of testing might be necessary.
So the second question is, what are the signs to look for with sleep apnea? And as the name implies, it is a condition that happens during sleep. And usually there are signs of airway obstruction that happens at different time during the night. And the signs of obstruction consist of labored breathing. So children who do have sleep apnea tend to have an increased effort in breathing in and out. They have noisy breathing, so they snore, and they might snore for part of the night or for the whole night. They might have excessive sweating during sleep. They also are not very comfortable sleeping. They wake up frequently. They are very restless during sleep. So these are signs that we look for during the night. There are some daytime manifestations of sleep apnea as well, and excessive fatigue, behavioral problems, possibly short attention span. These are daytime manifestations of any sleep disorder, and specifically for sleep apnea as well.
And definitely in older kids, we talk about school performance also being not quite as optimal as it can be.
Right.
The next question says, should we wait to have a sleep study until my pediatrician recommends it? I think the right answer for this is, if you're concerned about sleep, you should talk to your pediatrician and actually bring the issue up with them. We see an equal number of folks whose pediatricians actually brought up this issue and made the parents really more aware of it, and parents who really brought it up to their pediatricians. So I think most pediatricians are screening for sleep apnea now. The American Academy of Pediatrics actually recommends that children all be screened for snoring. And if it's positive, they look for some of the signs and symptoms that Dr. Amin just explained to you.
So the following question is, will my child with Pierre Robin sequence snore for the rest of his life or her life? So what is Pierre Robin sequence? Pierre Robin sequence is a condition where there is underdevelopment of the mandible, and the mandible is positioned backward. So it limits the space that is available for the air to go in and out and have normal breathing. Now, children with Pierre Robin's sequence, as I said, they have small mandible. There is, however, a continuous growth of the mandible over time. In very severe cases of Pierre Robin, where the mandible is extremely small, and when there is severe degree of airway obstruction, there is a surgery that is performed during the neonatal period or at an older age to increase the size of the mandible and reposition it away from the back of the throat. There is, however, as I said, a continuous growth that happens. Sometimes there is a catch-up growth and the child that no longer has persistent airway obstruction. In other cases, a second or possibly a third surgery might be required.
The other thing that's important, we did a study a couple years ago looking at some of the kids in the NICU who had Pierre Robin sequence, or at least small jaws. And we found that some of the kids with Pierre Robin had sleep apnea even if they didn't snore. So if you have a newborn with Pierre Robin sequence or with micrognathia or small jaw, you should think about airway obstruction or obstructive sleep apnea, even if snoring isn't the only thing that you're looking for. The next question actually says, can surgery fix my child's snoring? It really depends on what the airway looks like, and so we give a very individualized treatment in the clinic that we take care of. Some kids have large tonsils and adenoids, and so sometimes surgery can make the obstructive sleep apnea or the snoring go away. Some kids, even after their tonsils and adenoids come out, have other surgical procedures that can be recommended. Other kids actually find that they have persistent snoring or they have continued sleep apnea, and so those are the kids that we very specifically are focusing our attention on, both in our clinic and in our research, to see if we can help find optimal ways to manage them. There are other ways to treat sleep apnea other than snoring, both for kids with Down syndrome and Pierre Robin sequence and otherwise healthy kids. And so we do talk about a number of options that include both surgical and non-surgical options.
So my 5-year-old son has CPAP. What are some masks that work well for children his age? We have struggled with many masks. So CPAP stands for continuous positive airway pressure. It's a positive pressure that keeps the airway open during sleep and prevents the collapse or the obstruction of the airway during sleep. Now, pediatric institutions and pediatric sleep centers are much more familiar with the different types of masks used for children, and therefore I think it would be highly recommended to seek the input and the advice from a pediatric sleep center. There are many adult centers that perform and evaluate children with sleep apnea. While the evaluation might be very complete, finding the right equipment and the right size mask might be a challenge for those centers.
So the next question is it possible to be a very quiet sleeper, no snoring or gasping, and have sleep apnea? And the answer to this is definitely yes. The example I gave earlier of children with Pierre Robin or micrognathia is just one example. There are children who undergo tonsillar adenoid surgery, and even though they sound much quieter when they sleep, it may appear that they have no snoring, or they may actually have no snoring. And so it's not always the only indicator that we can use. The other thing that we sometimes find is that kids tend to snore in periods of time when most of us are sleeping. So there's a subset of children who have most of their snoring in dream sleep, also called REM sleep. Most of that tends to occur in the last half of the night when hopefully most of us are sleeping also. And so it may be that they only snore or have obstruction during those periods, and we're in fact not catching them if we're only checking them right before we go to bed or maybe first thing in the morning.
All right. The following question is, my son is a 6-year-old. He was diagnosed with chronic sleep apnea 1 year ago. He will not keep his mask on. At what point do we consider surgery? It's an excellent question, and there are about 30%, 40% of children who are prescribed CPAP who do have difficulties tolerating the face mask. And as I said earlier, it is important to ensure that the right size mask is being used and the right size equipment, the right size interface are available before seeking surgery. It is also important to ensure that the settings, the CPAP settings, are actually optimized before considering surgery. There will always be a certain percentage of children who will not tolerate CPAP. And I think in that case, it will be very important to seek the opinion of one surgeon, possibly multiple surgeons, in case there are some multiple reasons that contribute to airway obstruction. Not infrequently, there are children who do have craniofacial abnormalities, small mandible or other abnormalities, in addition to some soft tissue abnormality, enlarged tongue, enlarged tonsils. And in order to fully correct the problem, the child might need multiple approaches and several surgeries.
In the ideal world, you would want those kids evaluated by a multidisciplinary team who can all really work together and decide if they have the best approach, whether it be surgery or alternative masks or even medical therapies if it's very mild sleep apnea.
So my son has had an adenotonsillectomy and is still waking up frequently. He is a 3-year-old and will not tolerate CPAP. Is there anything else I can do besides medicine? Now, I think it's important to determine how significant the sleep apnea is and whether the frequent awakening and arousal from sleep is indeed due to snoring and airway obstruction. However, there is a very good possibility that sleep apnea recurs after adenotonsillectomy. And in that case, I think it's important to have a full evaluation of the anatomy of the upper airway to determine whether there are other structural reasons for having airway obstruction. So in the absence of enlarged tonsils, in the absence of enlarged adenoids, there are some other soft tissue within the airway that can cause obstruction, and it's important to identify those structures and possibly consider some other alternative approaches.
But again, those kids also can have other sleep issues, so make sure that they're sleeping enough in terms of getting enough hours of sleep. There are other reasons to wake up during the night, some of which are related to behavior. And so there's lots of things that a sleep physician can actually help you figure out, at least in a screening that may not all just be sleep apnea related. The next question is, my 4-month-old daughter has 7-to-1 hypopneas to apneas after undergoing a supraglottoplasty. Should we expect apnea for life or a cyclical behavior where it may go away and then come back? And I can tell you that we've learned more in the last 10 years or so that Laryngomalacia is a common thing that may in fact lead to sleep apnea. And so there are more kids undergoing supraglottoplasty, which is removal of some tissue on both sides of the area above the vocal cords that may be flopping into the airway and causing obstruction. For those kids, there's not as much long-term data, but the data that's out there shows that resolution of sleep apnea occurs in at least half of those kids. What we don't really have a great feel for yet is sort of the long-term history of whether or not kids who have some sleep apnea when they're young may in fact have it again when they're older. We definitely see kids who grow out of it over time. And so depending on how things look and how severe the disease is and how much it's having an effect on kids, we try a number of different therapies that may include things like oxygen, may include something like CPAP, may include other surgical procedures. And so I don't know that we have the full answer to this question, but we've definitely seen kids who resolve afterwards, and the jury is still out about what the long-term issues are going to be.
Right. The following question is melatonin safe for a 6-year-old with Down syndrome? The answer is yes. However, melatonin is a medication that it is prescribed quite frequently. It is available over the counter, and it is a medication that did not require FDA approval. So therefore, the complete safety profile of the medication has not been described by the FDA. The knowledge about the safety of melatonin is really acquired from our clinical experience in treating children and adults with this medication. It is very important to know the reasons for the prescription of melatonin. Melatonin has 2 different actions, has an immediate action, we call it a hypnotic effect. It helps children or adults to fall asleep. However, the main benefit from using melatonin is in children who do have what we call delayed sleep phase syndrome. These are children who can, or adults who cannot fall asleep at regular time. They stay awake in bed for 2, 3, 4, 5 hours. And in this condition and with this diagnosis, melatonin has proven to be quite effective. The administration of melatonin the time of the administration varies depending on the diagnosis. If the hypnotic effect is desired, then it's prescribed at bedtime. If the reason for the prescription of melatonin is delayed sleep phase syndrome, then the administration of the drug has to be 3 to 4 hours prior to sleep onset.
So the next question is, my child just turned 1. He has Pierre Robin sequence and trisomy 9 mosaic. He has had 2 jaw distractions, 2 supraglottoplasties, and still has pretty severe obstructive sleep apnea and central sleep apnea. He has an unrepaired cleft. What are our options? Now, I'm not sure I can answer specifically for your child, but we can give you some general information that this is the kind of child that we feel really needs a full multidisciplinary evaluation. I'm not sure what the effect of cleft repair is in kids like this. And in fact, we debate this quite frequently and have actually started looking at this in the kids who have clefts to see if there really is any effect on cleft repair and if we really need to delay them, if there's going to have some positive effect on their ability to feed and to develop speech and language over time. But it sounds like your child is one who probably has a lot of issues that would benefit from a multidisciplinary evaluation.
Our son is a 13-year-old and had 2 jaw surgeries and has Pierre Robin sequence. We had a sleep study with CPAP. It did not help. Is it neurological? I would say it is a little bit hard to provide an opinion here because in the very good majority of children who can tolerate CPAP, CPAP is very effective. So it is, I think, important to have additional information to determine what are the reasons for failure of CPAP. It is possible that the child needs, that your son or your daughter needs different settings on the CPAP machine. There are different modes that treat obstructive sleep apnea. Sometimes obstructive sleep apnea in Pierre Robin sequence is also associated with central sleep apnea. And in these situations, CPAP in and by itself is not enough.
So the next question is, how often do we need a sleep study for my daughter with Down syndrome? The current recommendations from the American Academy of Pediatrics are that all children with Down syndrome be screened for sleep apnea between 3 and 5 years of age. So if your child is younger than this and has symptoms, we think it's reasonable for them to get screened earlier. Even if they're asymptomatic or have no snoring, we still recommend that they get a sleep study between 3 and 5, and oftentimes we find that they're more likely to have sleep apnea than we recognize. If you have a child who's been treated for sleep apnea effectively, the question of how often they should get repeat sleep studies in the future is still a little unclear. We're working on some standardized treatment algorithms in our clinic to try and answer some of these questions. And really at this point, we're talking about looking in every year or 2 to try and get an idea in these kids over time. One of the reasons for that is as they get older, the likelihood of having sleep apnea is much higher. And it's unclear what the effect is of having previous tonsils and adenoids, but the studies look like even in those who've had tonsil and adenoid removal, a significant percentage, more than 50% of them, end up having sleep study as young adults. So depending on the age, at the very least at 3 to 5 years of age, they should have a screening sleep study.
So will medicine help my child with severe obstructive sleep apnea? There are multiple options in treating severe sleep apnea. Some of them are medical, some of them are surgical. As I understand this question, the question is, can non-surgical approaches treat severe sleep apnea? And the non-surgical approaches are the use of continuous positive airway pressure and CPAP. If tolerated, it can fully correct the problem even in very severe obstructive apnea. In the case of failure of CPAP, surgical options really are to be considered.
The other thing in older kids, if you're a teenage child, sometimes we can talk about things like oral appliances, which may also be useful, but usually require kids to have permanent teeth, so not something we talk about in younger children. The next question is, will reflux impact my child's sleeping? So reflux most definitely has a relationship with sleep. The most common time to actually have maximal reflux is actually in the middle of the night, about 1 or 2 o'clock in the morning if you're on a regular schedule. And reflux can actually increase the number of arousals during sleep, and then poor sleep, like sleep apnea, can actually increase the amount of acid. So there is a relationship between the two. Whether it's sleep apnea or not, it can definitely affect sleep.
My 3-year daughter has had a TNA and still has moderate obstructive sleep apnea. Should we try CPAP this early? And the answer is yes. Children who are 2 years old, 3 years old, can definitely use CPAP and tolerate CPAP. It might be a challenge in the very beginning to initiate this mode of therapy. However, if it is beneficial, there is a good chance that at this age, compliance would be very adequate.
The other thing, if it's really on the low end of moderate sleep apnea, sometimes there's a couple of medicines that we sometimes can advise people might help with the sleep apnea over time. They work best with kids with mild sleep apnea, but we do occasionally talk about montelukast or nasal steroids as medications that might be able to help. The next question says, we were told to get an MRI for my child's sleep apnea. Why? So one of the exciting things about coming to Cincinnati Children's is this is really one of the places where they pioneered something called cine MRI. And it's really an MRI or an X-ray evaluation that's done while kids are asleep with some anesthetic so that we can get a better idea of what kind of areas are causing them difficulty and causing them their sleep apnea. So one of the reasons we oftentimes talk to folks about MRI is for us to get this better idea of the location of the collapse. While a sleep study can tell us how bad sleep apnea is, it can't tell us whether it's something related to the tongue or whether it may in fact be something related to another area, like the palate or the nose or the jaw. And so the cine MRI really helps us in children who are 3, 4 years or older, less commonly done in the really young children. But we're finding it more and more useful, and it's one of the things that we actually review in our conferences as a team to see if we can help determine whether these are issues related to anatomy that may be able to be addressed by either bony surgery or soft tissue surgery, or in fact would be better addressed with something like CPAP.
So the following question is, my 17-year-old son with Down syndrome will not wear his CPAP. In his last study, he's had high number of events, but his oxygen saturation didn't drop more than a couple points, always above 90%. What are the risks of doing nothing? It's an excellent question. And of course, there are multiple factors that contribute to the pathology or the complications from sleep apnea. Of course, a frequent drop in oxygen saturation plays a big role in development of complications from sleep apnea, whether these are cardiovascular complications or whether these are related to body weight, obesity, some metabolic abnormalities. However, there are some other factors that also contribute to some abnormality, like disruption of sleep, very frequent arousals from sleep. So we do have children who do have frequent respiratory events. They do have frequent obstructive apnea. They don't have severe oxygen desaturation, but they wake up from sleep very frequently. So you might have seen a report of a sleep study talking about the arousal index, and usually you would like to see the frequency of the arousals less than 10 per hour. However, in some cases, they can reach 30, 40, 50 times an hour, and this causes severe disruption of sleep. Now the question becomes, what is the effect of sleep disruption on daytime functioning, on neurocognitive function, on intelligence? So there are some associations, of course, between disrupted sleep and abnormal behavior, possibly aggressive behavior. So it is important to put all these factors and the history into context before one could say that untreated sleep apnea is good, is safe, and you should ignore it. So it is very important to collect all the information possible and develop an impression on whether a child needs to be treated for sleep apnea or not.
So the next question is, my 8-year-old daughter with Down syndrome was fitted with BiPAP a month ago. She falls asleep great with the mask on but tears it off and won't let me put it back on. Is there anything I can do to help her sleep through the hour mark and keep her mask on? Well, there's a couple things this makes me think of. The first of which is sometimes people have difficulty leaving the mask on because they get some nasal obstruction, either from the mask itself or just from laying flat and gravity causing some of that. So sometimes we can treat the nasal airway with nasal medications or at least an evaluation to see if any of those are necessary. And for some folks, that actually helps them keep the mask on. In addition, there's some reward systems we use, just like I have to use at home to get my kids to brush their teeth. And so sometimes if you're helping them, we have some reward systems, they'll be more willing to put them on. And we actually have a desensitization program that helps kids wear their CPAPs and come up with some reward programs, although more commonly they work on helping kids with the initial acceptance. The other thing is that sometimes CPAP machines have a ramp, which means they start at a lower pressure, which works its way up while they fall asleep. And it may be that she'd be more comfortable if you can push the ramp or teach her to push the ramp, and it starts a little bit lower and comes back up. But we have a behavioral psychologist that we work with who can help individualize the treatment. And if your location near you it doesn't have one, that's something you might ask if they can refer you for one.
Can my special needs child have a sleep study? Does the sleep study have to take place in a hospital? A special needs child can have a sleep study, and the success of the sleep study is going to be very much dependent on the experience of the staff in dealing with children with special needs. When a sleep study is performed in an adult lab, quite frequently the staff is not very familiar how to handle children with special needs, and quite often the child either doesn't sleep or the study could not be completed. Does the sleep study have to take place in a hospital? In pediatrics, most of the study, the very good majority of the studies are done in a hospital settings because we do have children with special needs. This is a practice that is very different from adult sleep medicine, where a large percentage of adults with sleep apnea now are having sleep studies at home. At this stage, most of the sleep centers practice the same way where children come to the hospital, to the sleep lab.
So the next question is, can you generally talk about all treatment options for young children? It depends on what age we're talking about in terms of young children. Children under 1 year of age, we tend to do an evaluation to make sure there's not other reasons that might be contributing. So very young children have to breathe through their noses, and so sometimes nasal obstruction or things like choanal atresia, where there's blockage of the area behind the nose, may in fact be contributing to the sleep apnea. In kids with small jaws, that's an area that we oftentimes will evaluate and see if some kind of intervention needs to be done for Pierre Robin sequence or micrognathia. And so some of those include the distraction that Dr. Amin talked about earlier, but in other centers they may also do things like tongue-lip adhesion, or they may use things like nasal trumpets. So there are a number of options that have been considered for kids who are very young. We oftentimes look for supraglottic collapse or Laryngomalacia, which I mentioned earlier, and that's often associated with sort of a high-pitched noise when kids are breathing. We see the tissue above the vocal cords collapsing in and really causing some of the obstruction, and so sometimes we'll remove some of that tissue in order to improve the airway and breathing. As we talk a little bit older, it gets more likely that we're going to see some adenoid enlargement or tonsillar enlargement, and so kids at that stage, often first-line therapy for sleep apnea would be to remove tonsils and adenoids. Sometimes in kids under 3, the choice is made to remove adenoids alone when the tonsils aren't big, and both of those have been effective in improving sleep apnea or resolving it in some kids. If we're talking about options beyond adenotonsillectomy, then really sometimes we end up talking about looking for the anatomy that we talked about earlier with an MRI. So we may be looking for additional tissue on the back of the tongue called the lingual tonsils. We may be looking for tongues that are large for the space, like we oftentimes see in Down syndrome or in kids with micrognathia. We may look at other areas that might be collapsing in, like the side walls, and there are a number of different surgical procedures that can be used to tighten up the side walls or remove some of the tissue from the back of the tongue. But those are conversations that are had between all of the groups. Obviously, we still talk about oxygen in kids who are under 1 year of age, especially until they're able to easily tolerate a CPAP mask. And CPAP is actually used in very young kids, oftentimes started in kids 2 and older, and sometimes occasionally even in kids under 2. If it's very mild sleep apnea, we also sometimes talk about medications like nasal steroids or a medication called montelukast, both of which have been shown to reduce mild sleep apnea down to the normal range, but are probably not as effective if it's severe sleep apnea.
So my child with Down syndrome is tired all the times and will not wear her CPAP. How many times should we try CPAP? I think first of all, it is important to determine that there are no other reasons besides sleep problems or sleep apnea that contribute to daytime fatigue. Children with Down syndrome, they might have thyroid-related problems that could manifest with daytime fatigue. Now, in our practice, in our clinic here, we give the families and the parents two options. One option is to try to initiate CPAP at home. Many families opt to do that, and sometimes they are successful, sometimes they are not successful because it requires desensitization of the child to the face mask and to CPAP for several nights. And it is difficult for parents who do have daytime responsibilities to actually have this nighttime activity on a nightly basis for a week or so. So the second option is to bring the child to the hospital and have the respiratory therapist and the staff and child life to work with the child to desensitize him or her to the mask and to the use of CPAP. And the outcome of this approach is most of the time much better than attempting to initiate CPAP at home. So there is no limit on the trials of CPAP. You can try it multiple times, but I think it's important to have a plan that would ensure success with the desensitization.
So the next question is, how do you rule out central sleep apnea? And we use sleep studies to look at both central and obstructive sleep apnea. So that's usually the primary way that we look at both.
So how effective is ambulatory polysomnography versus traditional in-clinic polysomnography? And as I said earlier, 99% to 100% of pediatric polysomnographies or sleep study are done in the lab. There are no in-home sleep studies. Now, if there are some centers practicing this way, usually ambulatory polysomnography does not include brainwave recording. And brainwave recording during sleep allows us to determine whether the child is awake or asleep and what stage of sleep the airway obstruction or the breathing abnormality takes place. And it is a study that is unattended by a technician, so therefore one can see several artifacts that might interfere with the interpretation and reading the sleep study.
The other thing that's important is that a lot of the home sleep studies don't include carbon dioxide levels, which I think are really important in children. And they work on some specialized algorithms that have been made by programmers and don't usually use the same drop in oxygen level that we look for in kids, which is slightly different than what we look for in adults. And so it may really underestimate how likely it is to have the disease. So even in adults, if you think that there's likely sleep apnea and the sleep study looks normal, the recommendation is that they have to then go get an in-lab study. So if you are getting a home study, then you have to recognize that if it's positive, it really means something, and if it's negative, that doesn't necessarily mean that there's no sleep apnea, just that it wasn't picked up by a test, it wasn't very sensitive. The next question was, can low vitamin D contribute to sleep apnea? And I don't really have a good answer for this, do you?
No, I don't think there is any literature that links low vitamin D to sleep disorder, to sleep apnea. There is no abnormality of the control of the upper airway during sleep because of vitamin D deficiency. So what is the percentage of children with Down syndrome who have central versus mixed or obstructive sleep apnea? What are the best options for treating central sleep apnea? It is a very small percentage. The very good majority of children with Down syndrome do have an airway obstruction and they don't have central sleep apnea. If there is a central sleep apnea in a child with Down syndrome, most of the time there are some other reasons for it that might be related to a brain injury or might be related to untreated cardiac condition leading to heart failure or severe dysfunction of the heart. So again, it's important to determine the reason for central sleep apnea. If it is related to cardiac problem, then optimizing the treatment of the heart condition is essential. If in the absence of cardiac abnormalities, central sleep apnea could be treated in different ways. CPAP is an option. However, in these cases, we don't use CPAP. We use bi-level positive airway pressure. We use BiPAP. There are also medications that can stimulate the respiratory centers in the brain that might make those centers more sensitive and therefore could recognize the periods of central sleep apnea and try to avoid these events.
So the next question is, will my child outgrow sleep apnea as their body grows? And so some of this just depends on what else is going on and what kind of treatment. So if assume we don't do any treatment, no tonsil or adenoid removal, there was a study recently called the CHAT study where they looked at otherwise healthy kids and found that a reasonable number of older kids may be able to grow out of sleep apnea if they have mild disease especially. And we know tonsils and adenoids get bigger between 2 and 6 or 7 years of age. So if you have a 7 or 8-year-old with mild sleep apnea, it may be that as the tonsils and adenoids get smaller, they can grow out of that over time. But we don't have great data in terms of this regarding kids with Down syndrome. And in fact, most of the data shows that over time, they're more likely to have sleep apnea. So I think if we're talking about Down syndrome, it's probably not quite as likely. And weight, it continues to be an important issue for all of us over time, but especially in Down syndrome. So as we all gain weight over time, it becomes more common to have sleep apnea. With Pierre Robin sequence, I think I mentioned earlier, as jaw growth gets bigger, there may be an opportunity for there to be more space and you may be able to grow out of it, but it's something we need to keep track of over time because it's not something that we have great long-term data on right now.
So how many doctors will my child see in the upper airway center? I think this is going to be driven by the underlying problem that we have to deal with. As I indicated earlier, we have 7 disciplines involved in this upper airway center, and a child could be evaluated by all disciplines or could be evaluated by 2 or 3 disciplines depending on the diagnosis. So in children with Down syndrome, for example, the child is evaluated by a sleep specialist. Sometimes children with Down syndrome do have associated lung problems, so a lung doctor or a pulmonologist might be involved in this evaluation. Quite often an otolaryngologist will be present. A radiologist will participate in the evaluation of this child if a decision is made to evaluate the anatomy of the upper airway by MRI. A specialist in genetics, a genetics physician might be involved to evaluate the child, possibly provide counseling to the family, and oversee the overall evaluation of the child. If a child has Down syndrome, there are some other systems that need to be evaluated on a very regular basis that an otolaryngologist or a lung doctor does not focus on. A small percentage of children with Down syndrome do have other craniofacial problems that contribute to obstructive sleep apnea, and in that case, the plastic surgeon will be involved and will participate in the decision-making process and determine whether surgery on some bones, some craniofacial bones, might be indicated.
And the important thing, too, is even if you don't see all those physicians in the clinic, actually all of them are involved in the decision-making. We talk about every single case as a team before we see kids in the clinic. And so you'll get the collective decision-making of at least those 7 specialties, even if you don't see them all in person. The next question is, are there any neck or mouth exercises that could increase muscle tone such that it could ameliorate obstructive sleep apnea? Now, I know of 1 or 2 studies in adults where there are some exercises that they could do that help with some mild sleep apnea, but I don't know of any studies in children. And even those adult studies actually showed that you had to continue doing those exercises over time, and when you stopped doing them, that the sleep apnea would return. So this is an area that I don't think we have a lot of information, but it doesn't look quite as promising based on the adult data.
You mentioned the use of nasal steroid. My son is 4 and has used Flonase on and off monthly since 2014. Is he okay for long-term use to help reduce symptoms? I think it is quite often the need for nasal steroids is seasonal. And if there is indeed a benefit from using nasal steroid or possibly montelukast, I think it's reasonable to discontinue the medication after 6 months and determine whether the problem still persists.
So the next question is, how does resolving sleep apnea also resolve hypertension? And can the pulmonary hypertension return? So there's definitely data. I'm not clear if you're talking about both pulmonary hypertension and traditional hypertension, but there is data showing that the comorbidities, like both pulmonary hypertension and hypertension, can be reversible if we treat the obstructive sleep apnea. Most of those studies were done using CPAP and found that it can be very effective in improving these. Pulmonary hypertension is probably more your ball of wax than mine.
Right. Now, a child with obstructive sleep apnea and pulmonary hypertension, in almost 99% of the cases, the pulmonary hypertension is due to other reasons. And quite often in Down syndrome, there is an underlying cardiac problem that contributes to pulmonary hypertension. Now, in the presence of pulmonary hypertension, having obstructive sleep apnea, especially severe obstructive sleep apnea with frequent oxygen desaturation, doesn't really help. It could definitely worsen the degree of pulmonary hypertension. But obstructive sleep apnea in and by itself very rarely contributes to pulmonary hypertension. And it is important to rule out all other possible reasons for pulmonary hypertension before attributing this problem to obstructive sleep apnea.
So the next question is, our son with Down syndrome has had a tonsil and adenoid removal and doesn't tolerate CPAP. Could this contribute to weight gain and ADD? Now, a lot of times what we see is there's an overlap in the behavior that we see with obstructive sleep apnea and the diagnosis of ADD or ADHD. And so there may, in fact, be some contribution from the sleep apnea to the ADD, or at least the daytime behavior. We also see a very definite relationship between weight gain and obstructive sleep apnea. Some of it has more to do with tiredness, and it's hard because it is sort of a vicious circle. As the weight gain gets worse, the sleep apnea gets worse. And so actually recently we've started to integrate some of our colleagues who can help with medical weight loss, in addition to some of those who actually treat patients with surgical weight loss, and are working with some of the endocrinologists to see if we can help people avoid or at least identify some of the metabolic changes that may be associated with sleep apnea over time.
So what is the youngest age at which we can start CPAP? We can start CPAP at between 6 to 12 months. However, it is very important to rule out surgical problems that could be treated surgically before resorting to CPAP. And an infant with obstructive sleep apnea most likely will have a surgical reason for the disorder rather than a disorder that requires only CPAP.
So I'm going to jump a question, then we can come back. But the next one is, my child with Down syndrome is now a teen and keeps gaining weight. Can he have bariatric surgery? The criteria for bariatric surgery now goes down to about 14 years of age, although there are some centers that will consider it in children who are 12 or older. Bariatric surgery usually has a number of criteria that need to be considered. There's a number of comorbidities in association with weight that's elevated, and so we use body mass index, which is a way for us to figure out how overweight or obese kids may in fact be. The numbers are that a body mass index over 35 requires you to have at least 15 events an hour in terms of sleep apnea, or a number of other comorbidities that include things like high blood pressure that may in fact qualify you. And then kids who have a BMI over 40 then qualify if they have at least 5 events an hour or a number of other comorbidities. So it may be that teenagers may qualify for bariatric surgery. Regardless of that, we do recommend, and in fact they require, that everybody go through 6 months of supervised weight loss from a medical perspective before they can be considered for bariatric surgery, but it's a supervised weight loss, and there is data showing that decreasing weight can improve sleep apnea, although this is stronger data in adults than it is in children.
If you start CPAP young, will they need it forever? It's an excellent question. It is important to again, determine the factors that's contributing to obstructive sleep apnea. If weight or being overweight or obesity is an important factor, and this medical problem is not addressed. So obstructive sleep apnea will persist forever, and therefore CPAP will be needed long term. If there are some surgical reasons that could be corrected, then the answer is no. If the problem is corrected surgically, the child could actually wean from CPAP.
So the next question is, can you discuss tongue reduction surgery for patients like our son with Down syndrome? And what is the time or timing for tongue reduction surgery? So tongue reduction surgeries can be done in a number of different cases. In kids with Down syndrome, it's common not that the tongue is large, but that the oral cavity or the mouth is actually slightly smaller than it would be in some other kids. And so the relative size of the tongue for the space ends up being enlarged. We do talk about tongue reduction surgeries most commonly for the tissue in the back of the tongue. A number of years ago, we talked about doing things in the front of the tongue and found it wasn't quite as effective, although some kids who have really big tongues and can't close their mouth, sometimes will have tongue reduction surgery in the front. There are other kids who have, more commonly that we see, that they have enlarged base of tongue or that the back of the tongue is falling backwards. And similarly in Pierre Robin sequence, we can find the back of the tongue is falling backwards. And so sometimes we'll remove the tissue in the midline or in the middle of the tongue in the back, in the area that's most likely to fall back into the airway. This is done with an instrument called a coblator by most folks, which actually has significantly reduced the recovery for these kids. And then in terms of the time for tongue reduction or the timing, I don't know that I will tell you that there's a significant age at which is a minimum that we would consider it. But I think we've done it for kids who are 2 years or age or older in our center. And obviously would be happy to have conversations with people if they have specific questions when they come to the clinic.
So what type of specialist should I seek out to help my daughter with her sleep? We have seen a pulmonologist, but feel that there is more we can do. I think you are absolutely right. I don't think that sleep medicine belongs only to the pulmonary subspecialty. There are several sleep disorders that are unrelated to airway obstruction, unrelated to chronic lung disease. Some of them are behavioral in nature. Some of them are related to seizure disorder. Some of them are related to psychiatric disorder. So it is important to have the opinion of a board-certified sleep specialist, and for the sleep specialist to decide who would be the best person or the best physician or the best discipline that could help your child. It might be a combination, or it might be the involvement of several sleep specialists, each with a different background, who can help your child.
So there was a question I think I somewhat missed, which was, what's the recovery from tongue reduction surgery? And actually, some of it's a little bit variable depending on how well each individual person does. But the time frame we talk about is similar to the time frame for getting your tonsils removed, somewhere in the 7 to 14 day range. In adults who undergo tongue reduction surgery who've had tonsils removed before, they will tell you that it doesn't hurt quite as much as tonsils, but it's still a reasonable amount of time before kids are fully back to a regular diet and feel like the swallow feels like it used to before. The next question is, our son has had an MSLT study and qualifies as narcoleptic. I'm curious as to your clinical expertise with narcolepsy, and is this a possible misdiagnosis and possibly just daytime drowsiness? Our center has a number of sleep specialists, all of whom are comfortable taking care of kids with narcolepsy. We also have some specialists who are actually doing some research to help really make sure that we're doing the best we can to take care of narcolepsy and learn more in the future. It's hard to tell anybody on their specific child whether or not this is a misdiagnosis, but one of the reasons MSLTs or sleep latency tests are carried out with a sleep study the night before is in order to rule out some of the other sleep disorders that may be contributing to that sleepiness. So hopefully your child had both of those, and then they could put it in better context.
So the following question, my child tosses and turns. How could they keep a CPAP mask on even with desensitization? So this is a challenge in the first week or in the first week of initiating therapy. However, when a child is desensitized, that means that the child has perceived the benefit from the CPAP in terms of maintaining good quality sleep and sleeping without airway obstruction. So in the very good majority of the cases, the child no longer is restless during sleep, or possibly the degree of restlessness has significantly improved. And we see that in large percentage, especially in children with special needs, that once desensitized, they actually keep the mask on the long term. They do this better than adults sometimes.
And some of the tossing and turning is from the restless sleep from sleep apnea. So sometimes the restless sleep gets better with the CPAP. The next question is, what percentage of children with Pierre Robin sequence that have jaw distraction rely on CPAP for the rest of their lives? About 80% of kids who get jaw distraction actually have resolution of their sleep apnea, so it can be very effective for the sleep apnea or the sleep disorder breathing. In addition, a number of them will be treated with oxygen or some other modalities in the first year of life. And so oftentimes we find that these kids don't go on to CPAP, but there is, I would say, about 10% of kids who probably are in that range where they go on to CPAP.
So the sleep study is hard on my child, and she doesn't sleep at the study like she does at home. She has to sleep on her back at the study, but never sleeps on her back at home. Can the sleep study come back incorrect due to the restrictive sleep position? The answer is yes. And what we try to do in our sleep lab, and many sleep labs do the same, is we try to reproduce the exact same condition and the exact same environment as home. So if the child doesn't spend enough time sleeping on his back or her back, then we let the child choose the best position or the most comfortable position for him or her. Can the sleep study come back incorrect? It can come back incorrect. However, it does provide a very important information that if a child sleeps on his back and has an elevated index or very frequent obstructive events, that means that there is a risk that the child might spend a long time during the night on his back, on her back, and would have frequent obstructive apnea. Now, the best way of really determining whether a child has obstructive apnea is to do a full sleep study. We do recognize that this places a heavy burden on some patients and they cannot sleep in the lab, and we, in this case, we try to resort to some other ways of making a diagnosis of breathing disorder, and we sometimes monitor the oxygen saturation during sleep at home. So it's a monitor that goes to the home. It records the trend for oxygen saturation for a period of 8 to 12 hours, and we look at the trend. We look at the tracing and the frequency of desaturation, and we develop an impression on whether we are dealing with a significant degree of airway obstruction during sleep.
So the next question is, what orthodontic interventions are available if we had tried TNA and tongue reduction? Now, just because you've tried TNA and tongue reduction doesn't always mean that orthodontic interventions are necessary or available, but we do have people who are trained in dentistry and orthodontia who actually come and work with our team. Kids can get palatal expansion, and sometimes in kids with high arched palates, that can be very effective in helping with the sleep apnea. There are also surgical interventions that are designed to address both the orthodontia and some of the breathing issues, which our plastic surgeon, who's also an oral surgeon, can sometimes help us with. But it would really be very individual depending on the person, so it's something you should come in and get evaluated at your local center if that's a concern.
So will elevating the bed help obstructive sleep apnea? If we are talking about just elevating the head of the bed, then the answer is no. On the other hand, we have many children who choose to sleep in a sitting position because they can protect the airway better. So sleeping in a sitting position might minimize the degree of airway obstruction. Of course, this is not the best and the most comfortable way to sleep, but just elevating the head of the bed by, to 45 degrees will not treat obstructive sleep apnea.
And I think really that's related to the Down syndrome kids too, who we hear a history that they're not just sitting up, but they're flopping forward. And so that is something that may be opening their airway up some, but is probably not the best long-term solution. There are some patients where they've been convinced that was probably enough, and when we did the sleep studies in the position that they liked to be in, it really didn't usually resolve things. The The next question is, my 20-month-old has Pierre Robin sequence and Stickler syndrome type 1 and had jaw distraction at 11 days old. She passed the last 2 sleep studies. What is the protocol for a repeat study? I don't know what time frame you ended up getting those sleep studies in, but at this point we're actually seeing kids at 6 months and checking to see if they're symptomatic. If they're not, we usually do a sleep study at about a year. If they are symptomatic, then we'll go ahead and do the sleep study at that point. But again, this is an evolving field, so if your practitioners are advising things differently, that's probably reasonable at this point. We're still trying to figure out what the optimal time frame is to do some of these repeat sleep studies, but it's great that they passed the last 2.
All right, so after jaw distraction and the OSA has improved, should polysomnography be repeated and when? Again, this is a clinical decision. Quite often, the obstructive sleep apnea will recur in children with Pierre Robin sequence who did require mandibular distraction. It is important to know that the peak for obstructive sleep apnea is around the age of 3 and 4. So it is very possible that a child with Pierre Robin sequence who had a mandibular distraction could have recovered from obstructive sleep apnea for 2, 3, 4 years, and then the sleep apnea recurs when the tonsils are enlarged, the adenoids are enlarged. So definitely children with small mandible are at a greater risk of having obstructive sleep apnea in the future. It is important to monitor the symptoms. It is important to have an idea about the quality of sleep. And if the child starts to have noisy breathing, has restless sleep, it is important to bring this to the attention of the managing physician.
The other important piece is it's important to have somebody monitoring jaw growth, because it doesn't always, even if it got big and appropriate and normal size by the time they got their first distraction, doesn't mean it's going to continue to be that way over time. And so some kids find that while they do great for a couple of years, the jaw is still relatively small for their age and their size as they get older. And just like Dr. Amin said, just because you have Pierre Robin sequence doesn't mean you can't get large tonsils just like everybody else. So it's the same time frame that we'd be looking in other kids. The one last question was, will we see a sleep psychologist or a behavioral psychologist in the sleep clinic, in the upper airway clinic when we come? The sleep or behavioral psychologist doesn't routinely see patients, but coordinating visits on the same day can oftentimes happen if you give us a little bit of notice.
So the sleep psychologist doesn't attend the upper airway center clinic, but is available to see children with behavioral sleep disorder.
And does come to the upper airway conference, so does help us review patients when there's somebody that needs his expertise. So they are part of the team. They just aren't always in the clinic.